Yes, good evening, everybody, my colleagues, my friends. It's my honor today to launch the first episode of the Protection Summit. Actually, this Protection Summit is sponsored by a Bayer company and organized preparation by Icon company for technical support as well. Today, we are going to speak about the non-valvular atrial fibrillation in two aspects. We have two international speakers. One of them is local and international, and the other one is purely international, one of the godfathers of the treatment of atrial fibrillation and arrhythmia, Dr. Camm and Professor Magdy Abdelhamid. Regarding today, the non-valvular atrial fibrillation, we have to define the non-valvular atrial fibrillation. It is atrial fibrillation without prosthetic valve and without mitral stenosis. And this is very common nowadays. In the last 10 years, there is an advent of drugs which at that time called NOAC, or novel oral anticoagulant, but now it's called DOAC because it's direct oral anticoagulations. And all of us, we know a lot of trials regarding these drugs in the world, and now we are practicing the drugs and we have experience of the drugs, but we need advice. So the first advice would be by Professor Camm about the safety, on the comprehensive definition of safety for this patient non-valvular, how to define it's safe, it is different, if there is complication on diabetic, renal dysfunctions, if there is a bleeding, if there is a stroke, how to manage, how to define safety, and what is the drug safer than the other, is a difference between each other. And then the second part will be about atrial fibrillation PCI by Professor Magdy Abdelhamid, and this should be a different trials using, as we've done nowadays, PCI in patient with atrial fibrillation, or PCI in the patient develop atrial fibrillation, how to manage, is it using triple therapy, dual therapy, what are the trials, how to define these guidelines or not. So we need to have the experience, and then in between we have discussions. So I promise you that I will take care of all the questions coming from you, but please send the questions on the site, and then I collect it and then make a discussion. We have interactive discussion. And now I introduce the first speaker. Dr. Camm has, can you share your screen and then introduce you, please? Share the screen, yes. Dr. Camm is the honorary consultant cardiologist at St. George Healthcare Trust. I know Dr. Camm is about more than 20 years. I heard about any arrhythmia treatments, atrial fibrillation treatments, the name is Camm. So Dr. Camm is still practicing theories and his thoughts in treatments. That's why you are listening to him as if you are still students. Professor Camm became professor of clinical cardiology at St. George University of London, 1986. He continues to hold this position alongside positions as professor of clinical cardiology at St. George, and then also the Imperial College of London. He's internationally renowned expert in AF, and also is dealing with ventricular arrhythmias, ventricular tachycardias. Dr. Camm works towards a better understanding of atrial fibrillations. He has his research interests in cardiomyopathy, pacemaker, and also sudden cardiac death. He is a consulting editor for the European Heart Journal and editor of the European Society of Cardiology textbook of cardiovascular medicine. He has received numerous awards from his contribution to cardiology, including the British Cardiovascular Society Medal and European Society of Cardiology Gold. As you can see, is a very long CV, a lot of articles of Dr. Camm. So, and I think today he's have a unique lecture about the safety and definition of the safety for patients with non-valvular atrial. Dr. Camm.
Well, thank you very much for that very kind introduction, Professor Sobhy. I must say that I would rather be with you in Egypt rather than sitting here in a very hot London. But anyway, I'm pleased to talk to you all this evening. And the title of my talk essentially tells us that we're going to talk about what constitutes a good definition of safety for patients who have atrial fibrillation treated with an anticoagulant. Before I continue, I have to show you that I have numerous potential conflicts of interest. Most of these are professional society or editing roles, but some of them involve companies that have employed me to work on their behalf, and amongst them is Bayer. And Bayer, of course, is the sponsor of this evening's meeting, so please bear that in mind. I'd like to start our meeting by giving you the classic definition of safety of anticoagulants. It is essentially looking for the net clinical benefit between preventing stroke and not suffering from the hazards of bleeding. If it's in favor of preventing stroke, of course, we're usually happy to consider therapy, but sometimes it is the other way around, and then we can't bring ourselves sometimes to use an anticoagulant. But of course, there's far more to considering a comprehensive evaluation of safety. It's not just these two extremes. There are very many other considerations. And some of them that I'm going to discuss tonight involve the preservation of renal function, mitigating cardiovascular risks in diabetes, reducing the risk of dementia, dealing with the elderly, and trying to bear in mind that we give anticoagulants to prevent stroke. And we often forget that when we consider the hazards, particularly bleeding hazards. So let me now move quickly to the background to what I'm going to talk about. We know, and you know from old studies in the early 1990s, that anticoagulation, in this case with warfarin, produced a significant reduction, 64% in stroke, in this meta-analysis published by Bob Hart. Because of the difficulty in handling warfarin and other vitamin K antagonists, new drugs, originally called new oral anticoagulants, but now known as non-vitamin K oral anticoagulants or direct oral anticoagulants, were developed. And they were trialed against warfarin. And you can see in this meta-analysis published by Christian Ruff that there is a very significant reduction in hemorrhagic stroke and intracranial hemorrhage. There's a further 10% reduction in mortality added to the 26% reduction seen with warfarin. There's a small but insignificant improvement as far as ischemic stroke is concerned, and the hazard seems to be an increase in gastrointestinal bleeding. Now, if we look at the results that we're seeing now from the real world, we have confirmation of that kind of improvement. But what I want to show to you in particular, in this comparison between rivaroxaban and warfarin, that if we look not only for a reduction in stroke, but looking for a reduction in severe stroke and a reduction in post-stroke mortality, we can see that that indeed occurs with this NOAC drug compared with this vitamin K antagonist. Now, of course, we have to look at some further details of these studies with NOAC drugs against warfarin. When we do, in meta-analysis, we see there is a very specific reduction, statistically significant, but looking at major bleeding, we see it's not as even. Some drugs seem to reduce major bleeding and others not. But look at the trials themselves and notice that the patients in the trials were a very different risk. So Rocket AF, for example, with rivaroxaban, the average CHADS-2 score was 3.5, compared with Aristotle 2.1, Rely 2.1, and Engage 2.8. Now, because of this, if we want to compare real-world data with the Rocket AF study, we have to look at obtaining data, and we need to find the data in the average patients, like the Rely patients and the Aristotle patients. And the Xanthus study, a prospective registry study, demonstrated when we collected those patients over 1 year, there was a significant difference in terms of major bleeding and stroke. But because of this difference, the criticism was that perhaps we were not identifying all the events in this prospective study. And so another analysis had to be conducted, and it's illustrated on this slide. Here we're looking at the results with Xanthus and the results with Rocket, and we're going to do a ratio between the two. If that ratio is 1, it means the results in Xanthus and Rocket are similar. Now, of course, that's not the case if we take all the patients in Xanthus. But if we weight the patients, match the patients to the Rocket patients, we see that the results are very similar. The ratio is approaching 1, except for death. And of course, this is explained by the fact that patients in a real-world study are not excluded because they have serious comorbidities. Cancer patients, for example, are included. So death is likely to be more common in a real-world study. But if we look at vascular death or cardiovascular death, we can see the ratio is close to 1, implying that Xanthus is providing results which are very similar to the Rocket patients if they had a CHADS-2 score similar to Aristotle or Rely. Now, we also have recent real-world studies that have tried to compare drugs such as rivaroxaban, apixaban, dabigatran, etc. And this is a study that enrolled about 1,500 patients and looked at endpoints over a year or so of follow-up. And they found that major bleeding, for example, was particularly low in this study with rivaroxaban compared with others. And the reduction in ischemic stroke was also impressive. But there has been concerns about bleeding generally with NOACs, and therefore the European Medicines Agency decided to commission a study looking at the 3 common NOACs in Europe, and they, of course, are rivaroxaban, apixaban, and dabigatran. When they did this study, they found that the results were that there was very little difference between these NOAC drugs, and there was absolutely no reason to alter the indications for the drug. So that was a very important confirmation that there's not much difference between major bleeding rates. Now, because of all of these data, of course, we see in guidelines, both from the ESC and the AHA, that NOAC drugs are recommended in preference to vitamin K antagonists. And it's just the same in the American guideline. And these are class 1A recommendations. But there's no distinction drawn in this major indication between different NOAC drugs. Now, one of the biggest problems I think we all have is knowing what to do with elderly patients, because we can see that elderly patients are far more likely to have major bleeds on anticoagulants, and they're far more likely to have strokes. But we know that when we look at NOAC drugs in comparison with warfarin, even in the elderly, there is a significant reduction of stroke and systemic embolism, and bleeding rates are trending towards a reduction as well. Now, we have some specific studies, of course, in elderly or old patients. This one comes from France and looked at patients with an average age of 86. It was a comparison between rivaroxaban vitamin K antagonists, and you can see that major bleeding, intracerebral hemorrhage were both significantly reduced by rivaroxaban compared with warfarin, and there were trends towards a reduction in mortality and stroke. So these NOAC drugs seem preferable in the old. Now, we also, in this context, should remember that dementia is also much more common in patients with atrial fibrillation. And if we treat patients with oral anticoagulants, we can see that there is a significant reduction in the incidence of dementia in atrial fibrillation patients. And this reduction is particularly important in elderly patients. Now, there are also data developing demonstrating that NOACs are preferable to vitamin K antagonists, but we're waiting for the full publication of those results. Now, I'd like to move on at this stage to two important comorbidities, diabetes and chronic kidney disease. You can see that there is a very significant overlap in these conditions, and all of them increase independently the risk of stroke. Therefore, it's no surprise when we look at patients who, for example, have got chronic kidney disease, that we see that the rate of stroke is roughly doubled in data from the Danish National Database. And the rate of bleeding is almost tripled in these patients. If we again look at the major meta-analysis of NOACs versus warfarin, and we look particularly at patients who have impaired renal function with a creatinine clearance less than 50, we can see that for stroke and systemic embolism, there is a significant reduction compared with warfarin, and that there's a definite trend towards a reduction in major bleeding with NOAC drugs. Now, of course, we know also that all of the NOAC drugs are in part eliminated by the kidney. And because of that, we suspect that in worsening renal function, there will be higher concentrations of NOAC drugs in the blood. Here we see a comparison between the 4 NOAC agents, and those eliminated most by the kidney, of course, have much greater plasma concentrations in chronic kidney disease than drugs like rivaroxaban and apixaban, which are not so dependent on renal elimination. Now, because of the fact that renal impairment may cause an increase in plasma concentrations, the dosing schedules for all of these drugs involve consideration of renal impairment. And in ROCKET, in particular with rivaroxaban, a specific dose of 15 milligrams daily for all patients with a creatinine clearance less than 50 and more than 15 milligrams per minute was used. And this 15 milligram dose was tested in a large number of patients. It wasn't so simple with all of the other trials. And in particular, in Aristotle with apixaban, you needed other criteria like a low body weight or age in order to reduce patients. Therefore, for renal impairment alone, there's very little data with apixaban coming from the Aristotle study. Now, increasingly, of course, we're getting data from the real world in patients who have CKD compared with patients who have no renal impairment. And we can see from these real-world studies that patients with CKD seem to do particularly well, especially with regard to stroke reduction, with, in this case, rivaroxaban compared with warfarin. Now, we also know that patients with impaired renal function have progressive, continued impairment of renal function. So as you follow them year on year, there's a decline. in creatinine clearance. And in the ROCKET study, a group of patients who had worsening renal function, meaning a greater than 20% decrease in creatinine clearance, was studied. And as you can see, they seem to do particularly well with the reduction of stroke and systemic embolism and a tendency to the reduction of ICH compared with warfarin. Now, here comes a brand new concept that was really introduced by Yao and colleagues from the Mayo Clinic, looking at patients who had been prescribed warfarin or a NOAC drug. They followed them in the database for 2 years, and they looked at these parameters as indices of worsening renal function and showed that NOAC drugs, by and large, as a group, significantly reduced the likelihood of all of these adverse renal outcomes. And when they looked at specific NOACs, they found that this was especially true with rivaroxaban, somewhat true with the dabigatran, but not so apparent with apixaban. Now, of course, there have been many other studies since then coming from the real world. And just to illustrate one called RIVAL, this again was a database study looking at patients to see if they developed acute kidney injury or stage 5 CKD or needed dialysis. And we see that the hazard ratio was very substantially reduced in the patients taking rivaroxaban compared with warfarin. Now, these data and others, which I don't have time to show, encouraged the guideline writers from the AHA, the ACC, and the HRS to write this. Over time, NOACs, particularly the dabigatran and rivaroxaban, may be associated with lower risks of adverse renal outcomes than warfarin in patients with atrial fibrillation. Now, it wasn't a formal recommendation, but it's in the guideline text because this subject was just developing. Now we know a good deal more about it. In particular, we know something about mechanism. Acute kidney injury, for example, this is a hemorrhagic nephritis, patients get pretty ill and pyrexia, is essentially caused by inhibiting the production of thrombin, protein C, and factor 7 that leads to apoptosis, an increase in inflammation, and a disruption of the endothelial barrier, allowing red blood cells to escape from the glomeruli. That produces acute kidney injury. That's relatively uncommon, but much more common is the development of what's called renovascular calcification. And this happens because vitamin K is necessary to activate the matrix proteins which inhibit vascular calcification. And if you inhibit the activation with a vitamin K antagonist, then you get medial calcification of blood vessels, for example, in the kidney. And you can see here the decrease in renal function in patients exposed to vitamin K antagonists compared with those not exposed to a vitamin K antagonist. And if we look for calcification, in this case in the arteries of the limbs, we can see that over this 5-year period, there's a very significant increase in vascular calcification. We can see it in other territories as well. In this case, we're looking at a comparison between rivaroxaban and warfarin in patients looking at mitral valve calcification and aortic valve calcification. And we see that warfarin-treated patients have an excess of patients who have increased calcification, whereas patients treated with rivaroxaban have an excess of patients who have decreased or stable valve calcification. The same is true of the aortic valve. Now, because of this particular issue, with vitamin K activation being necessary to produce proteins that will suppress vascular calcification, we ought to look at the parallel, because vitamin K is also needed to activate osteocalcin, which is important to reduce risk of fractures and to reduce osteoporosis. And we're now seeing numerous papers that are coming along demonstrating that NOACs compared with warfarin, less rib fractures, and rivaroxaban in this particular paper was better than dabigatran. Now, because of this, I think we have to understand that NOACs have many advantages. But should we be using them in patients who have severe renal impairment? Well, we've begun to see some observational studies which suggest we should. For example, here's a comparison between warfarin and apixaban in patients who are on dialysis. And we can see that these patients had less major bleeding if they were taking apixaban compared with taking warfarin. And this was statistically significant. They also had less strokes, but it wasn't statistically significant. It's a little confusing about which dose of apixaban is better, because we don't know how it was chosen in this observational study. But in brief, it seemed that the patients who were receiving 5 milligrams twice daily had somewhat better results in terms of mortality and intracranial bleeding and stroke. Now, we've also had very similar results in similarly large numbers of patients comparing warfarin and rivaroxaban, and we see exactly the same, a significant reduction in major bleeding and a trend towards a reduction of stroke and systemic embolism. And recently, we've had a direct comparison between rivaroxaban and apixaban, and you can see there's absolutely no difference between the efficacy and safety of these two drugs in patients with end-stage renal disease. Now, we recently had some guidelines from the ACC, I've mentioned them before, and they suggest that in end-stage chronic kidney disease, we can use warfarin or apixaban. But remember that these guidelines were published in 2019, written in 2018, and therefore didn't have all the data for rivaroxaban, because then I'm sure they would have included rivaroxaban. Because the FDA, for example, in their drug labeling, give the doses which are needed for Xarelto and for Eliquis, rivaroxaban and apixaban, in patients on hemodialysis. So a tacit implication that rivaroxaban can be used. And this is just a summary of all that I've said about CKD. Patients with mild to moderate CKD, randomized controlled trial data showing NOACs are better. Patients with class 3B or 4 CKD, observational data, a little less quality data, but again, suggesting mostly that the NOAC drugs are better than warfarin. I've shown you what data there is for patients in stage 5 or stage 5D of CKD. Some nephrologists prefer not to anticoagulate these patients, and some prefer a left atrial appendage occlusion device. Now, I want to move to diabetes. You'll recall that diabetes has many characteristics which in patients with atrial fibrillation will increase the component parts of Virchow's triad and give rise to thrombus formation and stroke. So there are data in each of the large approval trials looking at diabetic patients with regard to CV death, stroke, major bleeding, and ICH. And I've put them all on this slide. You can see the results are a little discrepant trial to trial, but what I want to particularly point out is that CV death was statistically significantly less in patients treated with rivaroxaban compared with warfarin. Now, there are some difficulties with apixaban because although efficacy is very similar in the diabetic patients, safety is different, with less safety in the diabetics compared with the non-diabetics. But here again, there's important new data, not only showing that diabetics do just as well as non-diabetics with regard to these major outcomes of stroke, bleeding, and so on and so forth, but very importantly, if we look instead of just at MACE, but so-called MALE events, major adverse limb events, such as amputation, you can see that rivaroxaban does particularly well in comparison with other agents such as warfarin. Now, bear that in mind. Patients with peripheral vascular disease have also been studied, of course, in the COMPASS trial, admittedly with low-dose rivaroxaban in comparison with aspirin, but again, we see major adverse limb events being very significantly reduced. And recently, we've had yet more data, again, with the vascular dose, in addition to aspirin, compared with aspirin, where we see a very significant reduction in major adverse limb events and other adverse outcomes. Now, do patients with diabetes also have benefit in terms of not suffering further deterioration of renal function if they use a drug like rivaroxaban compared with warfarin? And the answer is clearly yes. Acute kidney injury is less, and the development of stage 5 CKD is less. And that's been shown in a number of studies. One I showed you was American. Here's a European study. And look how very significantly the hazard ratio is reduced with rivaroxaban compared with warfarin for end-stage renal disease and for the development of acute kidney injury. And we also see this, that it is irrelevant whether the patient has type 2 diabetes or not. The reduction in adverse renal outcomes is just the same in the diabetic and the non-diabetic patient. Now, just to round off this lecture, I want to say just a few words about the dosing of these NOAC drugs. We have specific dosing instructions, but it's very interesting to see that the proportion of patients who receive the wrong dose, an inappropriate dose, particularly an inappropriate low dose of the drug, is very substantial, as shown from prescription data and recently from data accumulated in the Garfield study. Is that important? Well, let's look at two studies that have been reported. The Danish study showed that particularly with apixaban, where you're falling down to 2.5 twice a day, in other words, halving the dose of apixaban, the ischemic stroke rate seems to increase. But the study from the Mayo Clinic showed a very dramatic increase, which was clearly statistically significant with regard to an inappropriate low dose of apixaban in terms of ischemic stroke. So take care, use the drugs according to the specific prescription. Now let's say a word also about bioequivalence, because all over the world we're beginning to get generics or copies of drugs such as rivaroxaban. And here are some of the rivaroxaban copies. Now, I've searched the literature for good bioequivalence studies to show that these copies are similar to the proper Xarelto form of rivaroxaban. And I can't find any. And you have to show that this particular finding, that the 90% confidence intervals for the geometric mean ratio of the Cmax and AUC between the two products should be within the acceptance interval. Now, there are no studies that I can find in the literature, and I am pretty concerned about using these copies in patients at present. One last word about adherence to anticoagulants. It is better with NOACs than it is with warfarin. It's better with once daily drugs than with twice daily drugs. And it's better in patients who are already taking medication for other conditions. But it's an important problem. We have to pay attention to it. So let me come back to the issue of what constitutes safety. Well, we have to take a much more holistic perspective. It's not just, is the bleeding rate equal to the stroke prevention rate? It's far more. And on this slide, I've illustrated not all of the considerations that we must weigh before choosing to anticoagulate a patient. But remember, the one major reason we want to prevent stroke, and stroke is a common complication, 5 times more than in patients who don't have the arrhythmia, in patients who have atrial fibrillation. So thank you very much.
Thank you, Dr. Jean. It is a wonderful lecture. Actually, there's a lot of items in this lecture. We can divide it, if you allow me, into the stroke, and then you go to the elderly and the dementia, kidney disease, diabetes, and vascular calcifications, renovascular calcification, which is a new term for us. We have to speak about again, about the dosing, about the stay on therapy, about the copies and genomics, and the adherence. So we have a lot. I think if we divide your lecture, you have more than 10 items. Let's go. I give you questions from the audience. I think can you stress again about the dose above the age of 75? What the meaning of elderly? It is 75 or 85, and how you calculate rivaroxaban? Give 15 milligram, 20 milligram, and others as well. Regarding the age in the elderly after definition.
A very good question, because it's frequently asked and it's frequently done wrongly. The definition of elderly varies from manuscript to manuscript, but the geriatric doctor has old, very old, and so on and so forth. And I think we can all agree that over 85 is an elderly patient. Those patients, if they have normal renal function with regard to the dose of rivaroxaban, get the full dose of the drug, in other words, 20 milligrams, not 15. Now, of course, many elderly patients have got impaired renal function with creatinine clearances less than 15 mils per minute. And in those, 15 milligrams is the appropriate dose. Now, with other NOACs, age, and this is particularly true of apixaban, of course, age equal to or over 80 is another factor to add to renal impairment or low body weight in order to reduce the dose from 5 milligrams twice daily to 2.5 milligrams twice daily. But age is not a factor for the prescription of rivaroxaban.
So whatever any NOAC, the dose is not affected in the elderly?
Well, with apixaban it is, not just because they're elderly, but if they have a low body weight or impaired renal function, in addition to being 80 or greater in age.
In your table for comparing the NOAC versus the VK, there is only disadvantage with the GIT bleeding. It is frequent in most of them. So how can you prevent?
It was shown in the randomized controlled trials with 3 of the drugs. It wasn't shown to be increased with apixaban. But remember, the patients in the Aristotle trial had far fewer bleeding risks than the patients in Rocket AF, for example, or the adoxaban study, Engage AF. So we have to bear in mind that the trials are not all the same. And therefore it's really difficult to compare one drug with another. There have been many attempts to compare real-world data, controlled trial data, but it isn't completely compelling. And so I think that we should not pick and choose on the basis of bleeding.
Can you share your screen regarding the slide of the kidney, of the EGFR, again, please? Because this is a lot of question regarding this. It's not so evident. Rivaroxaban for the dialysis or a patient on EGFR, because it's not so clear. We should have a hard points to regarding this. I mean, we have divided it's less than 15 creatinine clearance, or 30 or 60 or 90? Let's summarize again, please, because there are a lot of questions over there.
Yeah, well, I think it'd be nice if people just got a copy of this slide so that they can look at it. But here you see the creatinine clearance level.
And we can't see it. Can you share its screen, please, again? Share your screen and look to this slide. Look again. Come again to the share screen. Yes. Okay.
So here are the creatinine clearance levels calculated by the Cockcroft-Gault. Here is the CKD stage. Here is the need.
Can you use the pointer, please? Can you use the pointer for to show the audience? Use your pointer there on the computer.
Yes, I'm trying to get it, encourage it.
Okay, yes.
Here's the creatinine clearance. Here's the CKD stage.
Yeah.
Here is the frequency with which you have to retest the patient. This is moderate CKD. This is moderate to severe, and this is severe.
Okay.
Here is the clinical trial data, and here's the summary. Essentially, all of these patients, except the hemodialysis patients, there is some high volume data. It's only randomized data for the moderate CKD, not for the moderate severe. Here we're relying on an evidence base which is registry at a registry level. I showed you some of those details. And these patients can all receive a NOAC. Most of them shouldn't receive warfarin. At this end of the spectrum, many physicians decide not to anticoagulate. And if they do want an antithrombotic therapy, they often choose left atrial appendage occlusion.
So if you don't leave the slide, go to the RN, ARN. Also, two questions about the ARN again, because this is new, about the renovascular calcifications. What is the instance of the fractures with the decay? Because this is new. You said that it became important for this.
We have all known that patients taking warfarin do suffer from osteoporosis. And therefore, I think we're, in a way, used to that. What is the new teaching point is that the NOAC drugs do not produce that, because the osteoporosis comes about because you need vitamin K to activate the proteins that will cause bone calcification. And if vitamin K is not there, or if it's antagonized, then you will get osteoporosis. Now, that is not the case, obviously, if you're treating with a NOAC drug rather than a vitamin K antagonist. So that, I think, is the new teaching point, which is pretty important with these particular agents. And here I'm trying to show you that again. Can you see that?
Yes, we see. Yes, it's so evident. Yeah, real world observation and.
So yes. You can see this is a 5 or 6 year follow up, and you can see there's less with NOACs in general. It's more impressive with rivaroxaban than it is with dabigatran, as you can see. And this is the reason, the activation of these matrix proteins, which you see here on the slide. So good result, for example, with rivaroxaban.
Okay. If you're going to the cardiac surgery, I mean, dental extractions, doing abdominoperineal cholecystectomy, your advice, do you have a test before the procedures to, or you stop 2 days before?
Not for minor procedures. We just recommend that patient continue to take the drugs, but you do the procedure like a dental extraction with a once-a-day drug. You do it in the evening if they take it in the morning, and so on and so forth. So you just choose a period when the drug levels will be a little lower than they would be at other times. But otherwise, we don't make any adjustment to dose. We don't stop the drug, and so on. And I'm talking about minor procedures that will not cause any significant bleeding.
I'm taking the anticoagulation, and then I developed stroke. When to back to the anticoagulation?
Well, this is merely a consensus opinion. We don't have any data yet, but there are 3 big trials going on right now to find the answer. But currently, we say that if it's a TIA, you can go back the next day on the anticoagulant. If it's a mild stroke, you might leave 3 days. If it's a moderate stroke, you might leave 10 days. And if it's a severe stroke, you might leave up to 3 weeks, that sort of thing. It's consensus. Has nothing to do with any clinical trial data.
If I've developed intracranial hemorrhage, when I come back to the anticoagulation,
that's a much more
MRI, CT, then go, or I stop till the. There's no definite answer.
There's definitely no definite answer, but there are studies in this group of patients randomizing between NOAC drugs and left atrial appendage occlusion, for example.
Okay.
Many patients never restart an anticoagulant. Some with mild hemorrhage, which you've documented with, for example, an MRI, and you've shown that the bleeding has completely stopped. You can consider going back, particularly if it's a cause that can be surgically remedied, for example, or if it was an overdose or something of that sort. But generally, it's difficult to contemplate restarting an anticoagulant.
We don't have antidote in our country. What happened when we have a bleeding, massive bleeding, not mild? I mean, mild, you can stop and then repeat. The moderate is okay. But severe bleeding, we don't have antidote for dabigatran and for rivaroxaban. We don't have. So
no. Well, I think those countries that do have antidotes use it very little. That's the first thing to say. We have antidotes at my hospital. We've had idarucizumab, for example, for dabigatran for many years now, because we had it during the reverse AD trials and so on and so forth. We've used it not more than 6 or 8 times, not more than twice a year. So I don't think it's all that necessary in most instances. Of course, if you had it, it would give you much more comfort and you could use it in a particularly bad case. For the rivaroxaban patient who bleeds, it's recommended you use tranexamic acid, that you use activated PCC, and so on and so forth. There's some data with regard to what happens to clotting factors and so on, and to bleeding times, but there's no really good clinical outcome data.
Missed dose. I'm missing 1 or 2 days. Can I repeat again the same dose, or what can do?
If you've missed a single dose, if it's a twice daily drug, the 6-hour mark is the dividing point. So if you've missed a dose, let's say of dabigatran, and it's 4 hours later, take the dose, and then take the next dose on time. If it's a 12-hour, if it's a once-a-day drug, then 12 hours is the dividing point. Rivaroxaban, for example, you missed it. It's now 10 hours later, take it. If it's 14 hours later, don't take it. Just wait for the next scheduled time.
Okay, finally, the copy and generic. You have slides regarding the copies. Yes, in Egypt, we have more than 20 copies and generic for each one of them. We only have 3. But what do you think? How can in your country your advice? Because already we go to the governments in the insurance hospitals, in the military hospitals, in the governmental hospitals. They said that it's cheaper, and already they have the know-how coming from India, from China, and then finally they have a paperwork, and then the so-called bioequivalent. I'm sorry to say we don't have exact bioequivalents, but we have this. What's your advice for the copy? For example, identify what the meaning of generic, what the meaning of copy, and then your decision and your thoughts about this.
Well, I fully understand that, particularly when the patient has to pay for the drug, or for that matter, when the government is paying and is hard pressed, that a cheaper drug is potentially better than an expensive one. The trouble is that if you haven't shown that there is bioequivalence, you will definitely get into some kind of difficulty. So if you have the bioequivalence studies, then I think, okay, go ahead if you want to. That's fine. If you don't have bioequivalence studies, you shouldn't go ahead. The government should not support that. It's written down in stone what is necessary to show bioequivalence. It's not guesswork anymore. Now, with rivaroxaban, I couldn't find any bioequivalence studies. Now, with dabigatran, it's an even bigger problem because dabigatran is a very difficult, precise formulation. And all the drugs that are copies of and generics of dabigatran are dangerous, all of them. We know that because they cannot simulate what Boehringer Ingelheim did to produce dabigatran itself.
Okay. Regarding you give the dose for the diabetic patient with atrial fibrillation. I know Magdy is going to speak about the PCI atrial fibrillation, but can extend this question to you and Magdy as well. If I have a diabetic and I have a multi-vessel disease, I have an atrial fibrillation, I'm already on rivaroxaban 20 milligram, and I have a multi-vessel multiple stents. I know that the compass and the guidelines also that said after 1 year you can extend to 2.5 twice. But now I'm on 20 milligram or 15 milligram of. Do you think that the 20 or 15 acts like 2.5 twice in the prevention of a new atherosclerosis or stent thrombosis on the long run, or you gonna change into 2.5 twice?
It's a good question, of course. In atrial fibrillation, we really do not have the data for efficacy at 2.5 twice a day. We don't have it.
Okay.
We have some data with 15 and 10 coming from Japan and so on and so forth. We have nothing for 2.5 twice a day, even in addition to aspirin. But I think the vascular dose for patients in sinus rhythm, 2.5 twice a day, it has to be given in conjunction with aspirin to get the very good effect that was seen in Voyager, PAD, and in Compass.
So your practice for your practice of the Compass and Voyager peripheral, are you giving to all diabetic patients 2.5 twice for the peripheral artery disease to prevent what's known as MEL and MACE as well? All of that.
That is becoming a common treatment in the UK. It's not yet got into our major national guidelines, the NICE guideline, but doctors are voting with their feet. It's a very significant reduction in outcome events, and people are doing that.
So I think we have a lot of questions. I answered most of them. We have just a repetition. Thank you very much, Dr. John, and you join me for the next lecture. Thank you very, very much. Now shifting to Dr. Magdy Abdelhamid. Dr. Magdy can share a screen. And Dr. Magdy is the professor of cardiology, Cairo University, immediate past president of Egyptian Society of Cardiology, and the chairman of the working group of heart failure, and now he's one of the steering committee and in the board of European Society of Cardiology and Heart Failure Group, the board member of European Heart Failure Associations, and the fellow of American College of Cardiology, European Society of Cardiology, Royal College of Physicians, and Society of Cardiology. Thank you, Dr. Magdy. Dr. Magdy is a dear friend to me, and we work together, and we are preparing together the ECC Middle East Waves, 4 Wave. The next year we have an ECC Middle East Regional in Cairo in October. Dr. Magdy is going to speak about an important, I think this nowadays is an important part of our job, that we have a PCI patients, and these PCI patients have atrial fibrillation or patient develop atrial fibrillation. So what are the measures to protect AF patients that are going PCI? Now this should be the lecture name of Dr. Magdy Abdelhamid. Dr. Magdy.
Good evening, everyone. First of all, I'd like to thank my dear friend, Professor Sobhy, past president of the Egyptian Society of Cardiology, the governor of ACC chapter in Egypt, one of the leaders of cardiology in Egypt. Thank you very much, Professor Sobhy, for the kind introduction. Allow me to welcome our guest faculty, Professor John Camm, one of the known figures on clinical cardiology and past president of the European Heart Rhythm Association. And always I'm very happy to join Professor John Camm. And this is pictures were taken in Dubai on February in joint session together. So I'd like to welcome Professor John Camm today in this excellent webinar. Thank you. So as mentioned by Professor Sobhy, the subject of atrial fibrillation and patients who will be subjected to intervention, PCI, or develop acute coronary syndrome. We know that about 6 to 8% of patients undergoing PCI have an indication for long-term oral anticoagulation, either due to atrial fibrillation, which is common, or a mechanical heart valve or venous thromboembolism. So when we combine DAP therapy and anticoagulation, compared with oral anticoagulation therapy alone, the addition of DAP to oral anticoagulation therapy will lead to 2 to 3-fold increase bleeding complications. And this slide shows that we have 2 dual mechanisms of thrombus formation in patients with acute coronary syndrome. With the acute coronary syndrome due to ruptured atherosclerotic plaque with exposure of the subendothelial collagen and platelet activation and aggregation, this will lead to thrombus formation in patients with ischemia and acute coronary syndrome. At the same time, the release of tissue factor will lead to increased thrombin generation, and thrombin generation will be responsible for increased activity of the platelets and platelet activation and more aggregation. Thrombin will convert also fibrinogen to fibrin. So at this situation, we need antiplatelet therapy, which is an aspirin and the P2Y12 inhibitor like clopidogrel, prasugrel, or ticagrelor. And at the same time, we need an anticoagulation, either VKA or factor 10A inhibitor like rivaroxaban or thrombin inhibitors like dabigatran. So the combination of patients who have acute coronary event, there is a high shear stress and the platelet-rich thrombi. So the need is for antiplatelets, aspirin and P2Y12 inhibitors to prevent stent thrombosis after PCI. Patients who have risk for thromboembolic events, stroke, TIA, and systemic embolism, the low shear stress and less platelet-dependent thrombi, so they need an anticoagulation, which will protect them from more stroke and TIA. So the combination of these two strategy of treatment will increase the risk of bleeding. So we have to balance and we have to target the antithrombotic therapy to prevent the risk of ischemic events, stroke and stent thrombosis in patients with the AF and PCI, and at the same time to prevent the bleeding. So this is a challenge in these patients who are being treated with anticoagulation combined with DAP therapy, the risk of bleeding and the risk of thrombosis. And this is an interesting Danish registry included more than 11,000 patients for a varying degree of combinations, triple therapy, dual antiplatelet therapy, single antiplatelet therapy, DKA plus single antiplatelet therapy, and DKA monotherapy. And we can see that cardiovascular death, MI, or ischemic stroke were much lower with triple therapy as well as DKA and single antiplatelet therapy compared with single antiplatelet therapy. But however, the risk of fatal and non-fatal bleeding was high with triple therapy as well as when adding single antiplatelet to vitamin K antagonist. So this is a case study, a 68-year-old male patient who has non-valvular atrial fibrillation. He has risk factors in the form of diabetes, hypertension, and he's a smoker. He was subjected on 2013 to a PCI of the right coronary artery using 2 drug-eluting stents for the RCA. And he was in medical treatment in the form of combination of angiotensin receptor blocker and diuretic, oral hypoglycemic drugs, rivaroxaban 20 milligram per day, and statin as well. Recently, in the last 1 month, he is complaining of recurrent attacks of typical chest pain, occasionally at rest. And his electrocardiogram is consistent with atrial fibrillation, a rate of 75 beats per minute, normal QRS, no ST changes, and flattened T wave in multiple leads. Echocardiography showed an ejection fraction of 50%, LVH, diffuse hypokinesis, and dilated left atrium. He had no elevation of troponin, and he has normal hemoglobin, and his creatinine clearance is 95 milli per minute. If we want to risk stratify these patients, chest VASC score was 4, based on the presence of hypertension, diabetes, elderly, and vascular disease, and the HAS-PLET score, hypertension, elderly, antiplatelet. So he has a HAS-PLET score of 3. And this the slide which shows how to calculate Chat's VASC score, Chat's 2 VASC score, based on congestive heart failure, hypertension, age above 75, diabetes, stroke, TIA, or thromboembolism. And at the same time, HAS-PLET score can be estimated according to the presence or absence of hypertension, abnormal renal or liver function, stroke, bleeding tendency, lapide INR, elderly above 65, drugs like aspirin and non-steroidal anti-inflammatory drugs. So this patient is considered a high ischemic risk as well as a high bleeding risk. This patient was subjected to diagnostic coronary angiography. He was maintained on rivaroxaban, so it was discontinued for at least 24 hours before the procedure. Femoral axis after a switch from radial axis due to extreme arch tortuosity, and he had 2 vessel disease, proximal to mid-segment LAD, and very proximal circumflex. And his syntax score is around 22. So heart team discussion was done, and according to the data of coronary angiography, clinical data, he's diabetic. So the advantage of CAPG that he's diabetic and no need for DAPT after bypass surgery because he has atrial fibrillation, so class 1A for surgery in the presence of 2 vessel diseases proximal LAD. However, he had patent stents in the RCA and syntax score is not high. And according to the patient preference, PCI was considered. So when subjecting patients on NOACs like rivaroxaban for a PCI, how to deal with the antithrombotic strategy in the cath lab? It depends upon it is an elective procedure or it is an acute coronary syndrome. If it is an elective PCI, so stop NOAC at least 24 hours before intervention and using unfractionated heparin as usual, and prefer to use drug-eluting stents, and then to start NOACs as early as possible after procedure, as long as there is no evidence of bleeding or contraindication. Acute coronary syndrome, if the patient has STEMI or non-STEMI. Non-STEMI urgent procedure, like acute STEMI patients, we prefer to radial axis is recommended. New generation, drug-eluting stents, new generation is preferred. Additional unfractionated heparin should be given in the cath lab. Avoid 2B3A receptor antagonists unless pale-out indications, and avoid the fondaparinux. If it is an urgent non-STEMI, the same approach will be applied. While non-STEMI, non-urgent, stop NOAC for 24 hours at least, and then procedure after loading in both STEMI and non-STEMI with aspirin and clopidogrel. And then you can start the NOAC immediately after the procedure, and the PPI is highly indicated in those patients to avoid the risk of bleeding. And this is a very interesting 2018 joint consensus document by European Heart Rhythm Association, EAPCI, and Acute Cardiac Care Association. It is the same recommendations in atrial fibrillation patients undergoing PCI. If he's already on a vitamin K antagonist, so in the presence of any clinical indication, STEMI and non-STEMI, you have to continue the anticoagulation. You have to loaded him with aspirin and clopidogrel, and use a half-dose unfractionated heparin. While if he is on non-vitamin K oral anticoagulants, NOACs, it depends according to STEMI or non-STEMI. If it is non-urgent procedure like elective non-STEMI unstable angina, stop the NOAC 24 hours like before and load him with aspirin, clopidogrel, heparin in the cath lab, the usual dose that we given, and then continue with the NOACs. In the STEMI patients' urgent procedure, the anticoagulation should be continued, loaded him with aspirin, clopidogrel, and use half dose of unfractionated heparin. So this patient actually, rivaroxaban was stopped 24 hours, aspirin and clopidogrel was given, unfractionated heparin in the cath lab. He was subjected to PCI for LED and circumflex. So after this successful PCI, the most important question, which antithrombotic regimen for these patients after PCI? We know the triple therapy and the WOOS trial, use of clopidogrel with or without aspirin in patients taking oral anticoagulation and undergoing a PCI. This was an open-label, randomized, controlled trial. When comparing the triple therapy, warfarin plus dual antiplatelet therapy versus clopidogrel plus VKA, looking for the total number of TEMI bleeding events. The bleeding events was much lower with double therapy compared with triple therapy. And if we look for death MI, target vessel revascularization, stroke and systemic embolism, it was not different. So oral anticoagulation and clopidogrel only associated with significant reduction in major bleeding and no increase in thrombotic events compared with triple therapy with oral anticoagulation, aspirin, and clopidogrel. And if we go to another trial, which also looking for a comparison with triple therapy, 600 patients in the IDAR triple trial indicated for VKA, drug-eluting stent, acute coronary syndrome, or elective procedure, and the 9-month follow-up. And if we compare the 6-week use of clopidogrel only compared with triple therapy, and clopidogrel for 6 months, in addition also to aspirin and oral anticoagulation, we can see that comparison between 6 weeks and 6 months were not associated with significant reduction in death, myocardial infarction, stent thrombosis, stroke, or TEMI major bleeding, as well as the secondary endpoints. So to combine clopidogrel with VKA was much better than triple therapy. So what about NOACs? In the recent era of using NOACs in patients with atrial fibrillation, and as long as we have many patients who have atrial fibrillation who are indicated to be on oral anticoagulation, how to combine that therapy with NOACs after the procedure. So this is an interesting landmark trial, which is Pioneer AF-PCI. It's an open-label randomized controlled multi-center study exploring 2 treatment strategies of rivaroxaban and dose-adjusted oral vitamin K antagonist treatment strategy in patients with atrial fibrillation who undergo PCI. So this study included 2,124 patients with paroxysmal, persistent, or permanent non-valvular atrial fibrillation undergoing PCI, and the decision for adapt duration 1 month, 6 months, or 12 months, and the randomization either using rivaroxaban 15 milligram once per day plus single antiplatelet drug like clopidogrel, or rivaroxaban 2.5 milligram PID plus DAP therapy, which is an aspirin clopidogrel for 6 months, and then to continue with rivaroxaban 15 milligram once daily plus low dose aspirin, or the standard triple therapy VKA plus DAP therapy up to 6 months, and then VKA plus low dose aspirin. The inclusion criteria: medical history of paroxysmal, persistent, or permanent non-valvular atrial fibrillation, PCI, stenting, INR less than 2.5 in patients who are already on VK. And the exclusion criteria, patients who have history of stroke or TIA, creatinine clearance less than 30 milli per minute, contraindications for anticoagulation or antiplatelet therapy. So we can see that the baseline demographic characteristics was not different between arms of the study. However, we have Schatz VASC score of 3.7 average and Hasplett score of 3 or 0.9. So those patients are considered a high-risk patients for ischemic events as well as bleeding complications. And interestingly, that both rivaroxaban strategies, either the 15 milligram dose or 2.5 milligram dose plus DAP therapy, were associated with significantly improved safety compared with triple therapy regarding bleeding complications, TEMI major, TEMI minor, or bleeding requiring medical attention. And also we can see that the 2 doses of rivaroxaban compared with triple therapy, there was no significant difference in terms of cardiovascular death, myocardial infarction, or stroke. And the interesting finding is that hospitalization due to cardiovascular events and bleeding were both reduced significantly with the patients on rivaroxaban compared with warfarin. If we go to the guidelines, EC guidelines for management of atrial fibrillation, 2016. Patients with atrial fibrillation in need for oral anticoagulation after acute coronary syndrome. We have to identify the bleeding risk and ischemic risk. If we have a patient who has bleeding risk is low compared to the risk for ACS events or stent thrombosis, then it's recommended to give a triple therapy for 6 months and then combine oral anticoagulation plus aspirin or clopidogrel for 1 year, and then after oral anticoagulation as monotherapy. But if we have a patient who have a high bleeding risk compared to the risk of ischemic events, triple therapy is recommended for 1 month, and then up to 1 year, dual therapy, oral anticoagulation plus aspirin or clopidogrel. And after 1 year, oral anticoagulation only is recommended. So 2017, the EC focus update on DAP therapy in coronary artery disease. We can see also that patients with an indication for oral anticoagulation undergoing PCI, we have to look for the concern about the ischemic risk. So we extend the triple therapy up to 6 months, and then from 6 months, 12 months, the dual combination, and then after oral anticoagulation. But if the concern is mainly about bleeding, so a short duration of triple therapy up to 1 month, and then dual therapy up to 1 year, and then oral anticoagulation. So this is very important to risk stratify patients. Hasplett score is important, and estimating the ischemic risk events regarding stent thrombosis and ischemic stroke. Again, the guidelines recommended class 1C that it's recommended to give peri-procedure aspirin and clopidogrel in patients undergoing coronary stent. In patients treated with coronary stent, triple therapy with aspirin, clopidogrel, and oral anticoagulation should be considered for 1 month, irrespective of the type of stent used. It is a class 2A recommendation. Triple therapy with aspirin, clopidogrel, oral anticoagulation for longer than 1 month and up to 6 months should be considered in patients with high ischemic risk due to acute coronary syndrome or other anatomical procedure characteristics which outweigh the bleeding risk. This is class 2A recommendation as well. Dual therapy with clopidogrel and anticoagulation should be considered as an alternative to 1 month triple therapy in patients in whom the bleeding risk is high. How can we identify high-risk features for stent-driven recurrent ischemic events? Patients with the previous stent thrombosis on adequate antiplatelet therapy, stenting the last remaining patent coronary artery, patients with diffuse multivessel disease, patients with CKD with a creatinine clearance less than 60 milli per minute, at least 3 stents implanted, patients with the 3 lesions, multivessel PCI, bifurcation with 2 stents implanted, total stent length more than 60 millimeter, or treatment for CTO. So rivaroxaban, based on the Pioneer EF study, was recommended when rivaroxaban is used in combination with aspirin and or clopidogrel. A 15 milligram dose may be used instead of rivaroxaban 20 milligram. This is class 2B recommendation. And when NOAC is used in combination with aspirin and or clopidogrel, the lowest approved dose effective for stroke prevention tested in atrial fibrillation trials should be considered to avoid the risk of bleeding. And the same recommendation, 2019, the American Heart Association, American College of Cardiology focus update for guidelines management of patients with atrial fibrillation. According to the data from Pioneer EF-based PCI study, they recommended rivaroxaban in atrial fibrillation patients undergoing PCI with stenting for acute coronary syndrome. So in patients with atrial fibrillation, high ischemic risk for stroke, Shad's VASC score 2 or more, who have undergone PCI with stenting or for ACS therapy with P2Y12 inhibitor and low-dose rivaroxaban 15 milligram is reasonable to reduce the risk of bleeding compared with triple therapy. This is a class 2A recommendation, American guidelines. And the same for ECC 2019 guidelines that in patients who are eligible for NOACs, it's recommended that NOAC, apixaban 5 milligram PID, dabigatran 150 PID, edoxaban 60 milligram once daily, or rivaroxaban 20 is used in preference to VKA in combination with antiplatelet therapy. This is class 1A recommendation. But when rivaroxaban is used and there is a concern for bleeding, high bleeding risk, over concern for stent thrombosis or ischemic stroke, rivaroxaban can be given in a 15 milligram once daily, in preference to 20 milligram for the duration of concomitant single or dual antiplatelet therapy. This is class 2A recommendations. And after uncomplicated PCI, early cessation of aspirin 1 week after PCI, and the continuation of dual therapy with anticoagulation and clopidogrel should be considered if the risk of stent thrombosis is low or if a concern about the bleeding risk. This is considered a class 2A recommendation. Triple therapy more than 1 month if there is a concern about the risk of stent thrombosis or ischemic stroke and the low bleeding risk. How to avoid the bleeding while you are giving this combination of oral anticoagulation and antiplatelet therapy? Again, assess the ischemic and bleeding risk to identify the risk of each and the duration for the combination. Keep triple therapy duration as short as possible. Dual therapy after PCI, oral anticoagulation and clopidogrel to be considered instead of triple therapy. Consider the use of NOACs instead of VKA when NOACs are not contraindicated. Consider target INR in the lower part of the recommended target range. INR should be optimally not more than 2 in patients who were given vitamin K antagonist with the TTR more than 65 to 70%. Consider the lower NOAC regimen tested in the landmark trials which approved to decrease the risk of stroke, and clopidogrel is the P2Y12 inhibitor of choice. Use a low-dose aspirin up to or less than 100 milligram per day, and routine use of PPI is highly recommended. So regarding the bleeding complications which might occur during the treatment of this combination, and it depends according to the bleeding, whether it is a trivial bleeding not requiring medical intervention or further evaluation, like skin bruising, minimal conjunctival bleeding. In such situations, you have to continue that, and you have to consider oral anticoagulation continuation, or just only skip one single next pill dose. Reassure the patients, identify and discuss with the patients the possible prevention of this complication, and counsel the patients on the importance of drug adherence. This is very important. If the patients develop mild bleeding, a bleeding that requires medical attention without hospitalization, just as such as epistaxis, moderate conjunctival bleeding, genitourinary or upper lower GI bleeding without significant blood loss, In such situation, the same, continue DAP, consider shortening DAP duration or switch to a less potent P2Y12 inhibitor. If the patient, for example, on ticagrelor, you should shift to clopidogrel, and shortening the DAP duration to the minimum duration to avoid the risk of bleeding. And in case of triple therapy, consider to downgrade, such as escaping aspirin and giving anticoagulation plus P2Y12 inhibitors only. Identify and possibly treat concomitant conditions which increase the risk of bleeding, like peptic ulcer, for example, and add PPI if not previously given. While bleeding, which lead to hemoglobin deficit of more than 3 grams per deciliter and require hospitalization, while patients is hemodynamically stable and not rapidly evolving, such as genitourinary bleeding, lower GI bleeding. Single antiplatelet drug, it's preferred to be the P2Y inhibitor, especially in upper GI bleeding. Reinitiate DAP as soon as deemed safe for the patients. Consider shortening the DAP duration or switching to less potent P2Y12 inhibitor. Consider discontinuation of oral anticoagulation or reversal until bleeding is controlled. Reinitiate treatment within 1 week if clinically indicated. The target INR should not more than 2 in patients on triple therapy. And for NOACs, you have to give the lowest dose which can protect against ischemic stroke. And if the patient is on triple therapy, you are having to downgrade to dual therapy and escape aspirin. And if the patient is on dual therapy, consider to stop the antiplatelet as long as still the risk of bleeding is high. Consider IV PPI if GI bleeding occur. Identify and treat the concomitant conditions which increase bleeding and counseling for the patients. In cases of severe bleeding in which hemoglobin decrease 5 or more grams per deciliter, hemodynamically stable patients, the same measures should be taken, and consider to stop and reverse oral anticoagulation until bleeding is controlled completely, and reinitiate treatment within 1 week. And the lowest dose of oral anticoagulation should be given if the patients on triple therapy downregulate. In dual therapy, stop the antiplatelet and consider the same measures, IV, PPI, RPCs, transfusion, packed RPCs of hemoglobin less than 7 to 8 grams per deciliter. Consider platelet transfusion, urgent surgical or endoscopic treatment of bleeding source if it is possible. So the conclusion, ladies and gentlemen, that PCI in anticoagulated atrial fibrillation patients, the concern about bleeding and the bleeding risk reduction is very important. So there is a preference for the use of NOACs over VKA unless contraindicated. Consider shortening the combination therapy, oral anticoagulation, and antiplatelet as short as possible. For stroke prevention, there are proven anticoagulation and antiplatelet therapy options with proven stroke preventive measures at the doses which was used in the clinical trials. Ischemic event prevention, no definitive data, but aggregate data seems reassuring for shorter combination period and with full dose NOACs regimens. And remember that rivaroxaban is safe and effective in patients with atrial fibrillation who will be subjected to PCI according to the data of Pioneer AF study. Thank you for your attention.
Thank you, Dr. Magdy, for this wonderful lecture regarding the a lot of data in this lecture. Let me decide with you and patients عنده atrial fibrillation and they put stents or multiple stents. And they decide اولا ده already patient atrial fibrillation عنده multi vessel disease with stenting. فانت عندك you said trials اللي هو الوست ترايل وقلت البايونير والازار تريبل ترايلز. خلاص الوست هم دروب الاسبرين وهم كلهم بيديروا مع اورال انتي كواجولانت. not recommending this ازار تريبل the same. لكن البايونير هي starting of نوع. في 3 ترايلز ثانيه اللي هم ريديوال والاوجوستس وانتراستس. what's your opinion about these trials in relation to Pioneer? هل هو there is difference in the use of other NWAC for the PCI with atrial fibrillation? Is it the same dose? ولا it should be for the في guidelines you said the rivaroxaban with atrial fibrillation decreases from 20 to 15. فهل الريديوال والأغسطس والانتراستس the same ولا you should have the same dose?
Okay. Yeah, the same rationale for the three trials. Redual for dabigatran 150 and 110 milligram. Augustus, it was two randomization, VKA versus apixaban, and then randomization aspirin versus no aspirin. And in the dose of 5 milligram twice per day, except patients who are above 80 or patients with creatinine 1.5 or more and body weight less than 60. If you have two criteria or more, 2.5 milligram, this is the recommended dose. And the outcome of Augustus trial revealed also that escaping aspirin was better when giving apixaban plus aspirin compared with the triple therapy. That dual combination compared with triple therapy was associated with significant bleeding reduction and without non-inferiority regarding ischemic complications. Patients in Pioneer, which is a big study, and compared the two different doses of rivaroxaban, 15 milligram plus clopidogrel, 2.5 milligram PID plus DAP for 6 months, and then 15 milligram and clopidogrel, and compared with the triple therapy. The patients with Pioneer AF study are high-risk patients. High-risk patients based on the Schatz-Vasque score, which was around 3.9, and the Hasplit score, it is more than 3. High-risk patients means those patients are exposed to the risk of ischemic stroke and the risk of bleeding complication. And usually the high ischemic risk are also a high bleeding risk. So Pioneer AF proved that the use of rivaroxaban, even in a dose of 15 milligram, which is not the recommended therapeutic dose, which is usually 20 milligram. But in patients in Augustus, apixaban using small dose carry the risk for stroke events. So Pioneer proved more evidence for protection of stroke and protection from bleeding in those high-risk patients, even with the dose of 15 milligram. So the guidelines recommended that class 1A to use 20 milligram in those patients and 15 milligram if you have a concern about the risk of bleeding. You can use a 15 milligram very confidently that there is no risk for ischemic stroke with 15 milligram. So this is the difference between the combination of different nodes.
And عندنا patients now اللي هو عنده high ischemic risk, you have a table اللي هم multiple stents والmultiple lesions last remaining so and so. في عندنا category تاني، اولا two categories. one duration of antiplatelets، انت بتاخد depth مثلا precise depth ولا في other factors. والسؤال الثاني next questions the high bleeding risk patients, how to identify the high bleeding risk patients and what making the duration or the depth is more than 1 year, how to identify and do these two questions.
Yeah. To identify the risk of bleeding, we know the Hasplit score is a very simple score which can be calculated very easily. That the Hasplit 0 to 3, it is low to intermediate risk. 3 or more is a high risk bleeding patient. So according to hypertension, abnormal liver and kidney function, lapile INR, stroke, elderly, using drugs, non-steroidals and aspirin. These are the components or variables of Hasplit score. So there is no doubt that Hasplit score can be easily used to estimate the risk for bleeding. Okay. Then the duration after giving the triple therapy for the shortest duration, according to the bleeding risk. If we have a patient with high bleeding risk, I will give him triple rivaroxaban, aspirin, and clopidogrel for 1 month only. And then after 1 month, I will keep him on rivaroxaban and clopidogrel for up to 1 year. And after 1 year, I will maintain him only for oral anticoagulation. But if the patient has low bleeding risk, so the triple therapy for 6 months, and then after 6 months to 1 year, the same rivaroxaban and clopidogrel, and after 1 year, only oral anticoagulation. The extended duration of DAPT to be judged according to DAPT score, the precise DAPT. This is another subject based on the risk for ischemic events in high-risk patients, left main multivessel disease, diffuse atherosclerosis, diabetic patients, CKD, heart failure patients, etc., etc. Those patients, according to Pegasus trial, that the extended DAPT beyond 1 year have a benefit in terms of reduction of ischemic events. But those patients were sinus rhythm patients, not an atrial fibrillation patients. So in atrial fibrillation PCI, after 1 year, this is the standard duration for DAPT, and after 1 year, you are giving only NOACs for prevention of stroke.
هو اكستنت طبعا انسر، لكن في حاجات سهله شويه كده شفتها قبل كده. طبعا دكتور جون كام اي ثينك هيز ليفت سو سبيك، عشان كده شويه فرانكو اراب يعني ان في مثلا جيرم ديسكو عمل حاجه اسمها اي بي او، او يعني ايه اي بي او؟ يعني قال لك الايدج والبي يعني بليدنج والاو يعني اورجال ديسفانكشن عشان تايدنتيفاي هاي ريسك. يعني مثلا الناس اللي هم فريل بيشنتس مور ذان 75، لو عندك ادفانسد ايدج more than 85، لو عندك لايف اكسبكتنسي اقل من 1 year، بليدنج باي حاجه زي ما انت قلت، مثلا هيموجلوبين قليل، ريكارنت جي اي تي، سبونتينيوس، اورجان ديسفانكشن، يبقى سهله اي بي او، عندك ليفر، عندك كيدني، عندك بون مارو، عندك ستروك. يبقى الاربعه دول الاورجانز او البليدنج او الايدج بيسهل لك ان انت تشوف بليدنج زي ما انت قلت. لو انت عندك هاي بليدنج ريسك من الستارت فلازم تعمل شورت ديوريشن منه. الحاجه الثانيه ان انت يو هاف تو، طبعا انت قلت الراديال وقلت البي بي اي وكان الستانس كمان، لما في 2 ستاديز الستانس اللي هي اونكس عشان الاونكس او الباي فريدم، يمكن تختار الستانس اللي عايزه شورت ديوريشن، يعني في كليمينج 1 مانث 3 مانثs بس. يبقى انا عندي الستانس وعندي الدراج وعندي تريبل وعندي دبل. الاحسن في الريفاروكسابان ان هو الستاديز بتاعته اوضح وهو موجود وحيد في الجايد لاين ال 15. يعني انت ممكن يعني تكريز الاذرز، بس البروبلم ان هو will not prevent the stroke بالسمول دوز زي ما الدكتور جون كام قال ان انت you have to make the full dose. فدي حاجه very very important انت قلتها في الجايد لاينز وهو قالها في الجايد لاينز برضه. عشان كده ليه ريفاروكسابان is preferred نواك في البيشنت بي سي اي، لان الدوز اللي بتمنع البليدنج هي الافكتيف برضه بريفنشن ستروك، لكن الاذرز الدوز اللي بتمنع ستروك مش هي الدوز القليله اللي انت بتمنع بليدنج. طب انا ما فيش امبورتنس ما بين عشان كده بقول لك الاوجستس والدول انترستس بالرغم ان هم دول، لكن الايفكت منهم ما غيرش جايد لاينز غير في الدبي جاترينا 110، قال لك 110 بدل 150. ما اعرفش انا حاجه ثانيه فيها. الاسئله اللي جايه ثانيه او من عندنا برضو ثاني عايزك تقول لي على البري تريتمنت في الناس دول. يعني انت في البي سي اي الاتريال فيبريليشن هل بتعمل لهم بري تريتمنت كلوبيدوجرال ولا ما بتعملش؟ وفي النون اس تي مثلا او اس تي ما هو تفرق، البيشنت بتوعك ستيبل او نون اس تي او ستيمي تعمل ايه؟ هو ماشي على بري لودنج.
Yes, loading with aspirin and clopidogrel as mentioned in the guidelines, and you know that the preferred P2Y12 inhibitor in such cases is clopidogrel, not ticagrelor. The only indication for tica patients who develop stent thrombosis while he is on clopidogrel. This is the only indication to combine anticoagulation with ticagrelor. But the standard and the recommended is to combine the anticoagulation with clopidogrel. So preloading with aspirin and clopidogrel is recommended. Unfractionated heparin in the cath lab is recommended. Radial approach is recommended. New generation drug-eluting stents is recommended. no 2B3 receptor antagonist to avoid the risk of bleeding unless the bailout in stent thrombosis. These all the guidelines.
اعترض معاك على النو تريتمنت، لان في ترايلز برضو دلوقتي جديده من القصه دي بيفضلوا عشان البليدنج ايشو از مور ان انت نو بري تريتمنت، حتى قارنوا بالبري تريتمنت البيشنتس والنو بري تريتمنت اند بوينتس لقوا الريسك بليدنج قليل قوي، ما بقاش 2%، والتاني ريسك بليدنج انت بيكوز يو دونت نو ان ذيس بيشنت، فاتس بيتر ان ما فيش فرق في التريتمنت لو انت داخل انت تعمل يعني
برايمري بي سي اي
برايمري بي سي اي انت داخل بيه، لان صح البرايمري بي سي اي كلهم لو انت عندك اتريال فيبريليشن. السؤال بقى مجدي، لو انت ما كانش عنده اتريال فيبريليشن والعيان ده جالك ستيمي او نون ستيمي ورحت مديله مثلا تيكاجرول او برازوجريل، والعيان ده جالك باتريال فيبريليشن، ار يو جوينج تو تشينج ولا تكونتينيو برضه مع تيكاجرول ولا برازوجريل؟
No, I will change to clopidogrel of course because the bleeding complications will be high.
خلاص يبقى احنا في الستيمي اتفقنا على بري لودنج، ولو حصل اتربيشن او كلوبيدجرول دراج اوف تشويس حصل نغير. في النون ستيمي نو برو تريتمنت، ولو في اتربيشن كلوبيدجرول برضه راديال ابروتش بي بي اي اند شورت ديوريشن. I think no question. Thank you Magdy very much. It's يعني wealth of knowledge بينك والدكتور جون كام، وكان منافسه حقيقيه واضحه. برافو يا مجدي بصراحه، يعني كان توك كويس جدا جدا. واي ثينك ان احنا النهارده اشتغلنا على الاسكيميا واشتغلنا على حاجات جديده قايلها الدكتور جون كام اللي هي بتاعه الاي ار ان والكالسيفيكيشنز والاي جي اف ار والديمنشيا. هو قال ديمنشيا مهمه قوي تمنع الديمنشيا، يعني احنا ما عندناش فكره ليه بتمنع فلازم في الادي تمنع الديمنشيا، ودي حاجه مهمه بالنسبه لنا ما كانتش قائمه بالنسبه لنا. الدايابيتك في البريفرال وقال الكومباس ترايل دي ساعدتنا، فاجير برضو نفس الكلام. وانت برضو ايدت بقى موضوع البي سي اي واتريال فيبريليشن بالبايونير والوست والزارز. ثانك يو فيري ماتش. معلش احنا ويك اند يا دكتور مجدي انا وانت النهارده ونكمل بقيه الماتش بتاع مانشستر سيتي بقى وريال مدريد. يلا ثانك يو فيري ماتش. ان شاء الله. I'd like to thank Bayer و Icon Company. Thank you very much.
Thank you very much. Thank you. Bye.